Good morning, good afternoon, good evening po sa lahat. Saan mo pong panig kayo naroon. Welcome to our 251st, if I'm not mistaken, na episode for our Health Updates webinar series brought to you by the University of the Philippines. Thank you for being part of our credible online community, and for all those who have just discovered us today, welcome po at sana po marami po kayong matutunan. Ito po kasi very nuanced po, no? Hindi po siya masyadong napag-uusapan, kaya po we want to shine light on it, highlight it some more, and I'm talking about antimicrobial resistance po. So sa panahon po ngayon, meron pong antimicrobial resistance, yung pong mga mikrobyo, nagkakaroon po sila ng resistensya sa mga antibiotics, sa mga gamot po nating ginagawa. This poses a significant and escalating threat to global public health, and yung pong imperative na dapat po tama, rational yung pong antibiotic use has never been more critical. Like in many nations po, no, yung Pilipinas, we grapple with the complex challenges of AMR, or antimicrobial resistance, which jeopardize the efficacy of those treatments. Imagine niyo po, no, nasa ICU po kayo, natamaan po kayo ng mikrobyo, yung pong lagi pong binibigay na antibiotic, for some reason hindi na po siya gumagana kasi nagkaroon po siya ng resistensya yung mikrobyo po, no? So yun po yung ibig pong sabihin ng efficacy of life-saving treatments and how it increases healthcare costs and morbidity po. So sa ating episode po for this week, our distinguished panel of experts will talk about the judicious use of antibiotic for prophylaxis in surgical procedures like caesarean sections, management of common urogenital and pelvic infections, and the critical importance of diagnostic stewardship po to minimize unnecessary prescriptions. This is the Health Updates program, and I'm your host, Dr. Raymond Francis Sarmiento. Always a pleasure to be with all of you during our regular Friday, and also my pleasure and honor po, no, to co-host this program together with Dr. Stella Mariose. Ma'am Stella? You're on mute, Mama. You're on mute.
Ayan. Good
Yan, okay.
afternoon, Doc Raymond, and hello to all our participants here in the live broadcast of the Zoom webinar, and to all those watching via live streaming at the TVUP YouTube channel, as well as the UP System Facebook page, the TVUP Facebook page, and of course, those watching from TVUP Signal TV channel 101. Our main presenter for today is Dr. C.B. Lizan Bravo, who is the Chief of the Division of OBGYN Infectious Diseases at the UPPGH Department of Obstetrics and Gynecology. She is also the immediate past president of the Asia-Oceania Research Organization in Genital Infection and Neoplasia Philippines, and the Philippine Infectious Disease Society for OBGYN. And reacting for Dr. Bravo is Dr. Nikita Valerie Chua. Sorry. Sorry for this. Nagka-technical glitch ako. I'm
No
sorry.
problem.
Oh, and so we also have Dr. Nikita Valerie Chua, who will be her reactor. And for this afternoon, we want you to sit back, relax, and listen to this lecture by Dr. Sibyl Bravo and the importance of antibiotic stewardship. And of course, we have also our other aspects of the webinar. And so sit back, relax, and listen to the lecture. Back to you, Raymond.
Thank you, Ma'am Stella. So just to continue lang po, no, Dr. Nikki Chua, we already had her before. She's the head of the section of OBGYN infectious diseases at St. Luke's Medical Center, Quezon City. Also faculty from the Division of OBGYN infectious diseases of the UPPGH Department of OBGYN. Also a member of the Task Force on Reproductive Tract Infections of the Philippine Obstetrical and Gynecological Society. Okay, so we'll be discussing po, no, paano po ba natin matututunan, paano po ba mape-preserve ang effectiveness of the antibiotics for generations to come. At para po mas maintindihan po natin ito, meron po tayong in-interview. Yung in-interview po natin, part of our person on the street video. It sets our discussion into context po, no? Very, very short video produced by our webinar team po. Na questions that we pose to our interviewees are as follows. Ano po ang alam ninyo tungkol sa antibiotics po, no? Sa pag-inom o pagturok ng antibiotics? Ano-ano ang alam ninyong naitutulong ng antibiotics sa inyo Sa tingin po ba ninyo, kailan po kaya dapat at hindi dapat gumagamit ng antibiotics? At alam niyo po bang maaaring magkaroon ng resistance ang mga impeksyon sa mga piling antibiotics po, no? Kung alam po ninyo, ano po ang alam ninyo tungkol dito? Please watch this.
Antibiotics are consumed whenever someone has a particular sickness or disease wherein the bacteria in someone's body needs to be combated. So I know that there are specific antibiotics for specific sicknesses and diseases.
Nung bata ako, alam ko gamot lang siya sa ubo. Gamot pag may lagnat, ganun. But as I grew up, I knew that antibiotics is a prescription drug, so hindi dapat talaga siya iniinom.
Antibiotics are the things that we take that are strictly not over the counter. That needs a reseta to get from pharmacies.
Antibiotics are a defense mechanism, so they can help someone in speeding up how they heal or how they recover from a particular disease.
Antibiotics is good when taken properly, especially sa mga sakit na kinakos ng mga bacteria or viruses. The cons is that hindi siya basta-basta dapat iniinom.
Well, obviously, for faster healing, because sometimes I think, I'm not sure, I'm an artist, I'm not a doctor, so I think our antibodies sometimes are not enough to combat some bacteria.
I do know of some people who have this kind of antibiotic resistance, which is why it's all the more important to really consult a medical professional or a health professional about how to deal with the certain sickness or disease that you have, and to not just consume antibiotics.
From what I know, our antibodies or our bodies are not able to combat some things that go into our body by themselves. So we need antibiotics.
I know that antibiotics should only be taken when they are prescribed. You also have to consider that you're taking the proper antibiotics for that specific disease or sickness, and also you need to make sure that you're taking the right dosage.
Only if it is prescribed.
We should only use antibiotics if and only if we have a prescription from a licensed professional.
And make sure that it's a professional who's giving this prescription in order to make sure that this does not have any adverse side effects on your body.
I don't think it's something that you should believe or not believe. Parang if professionals tell you na you should take antibiotics dun sa time na they said na prescribe, at kapag nasabi lang nila that you should follow them because they are the ones who know better and who understand the body.
It also has to be something talaga that's consulted with a health professional before you dive into it. And I think that highlights even more that awareness about these things, about consuming medicines, and about taking the right medication and approaching the right people when it comes to dealing with these sort of sicknesses is important.
Okay, thank you so much, TVUP. Always refreshing that meron na po palang nakarinig nito, or at least alam po nila kung ano pong ibig sabihin po ng judicious or rational use of antibiotics. Take this opportunity po for a little bit of housekeeping. All those who have or are asking for certificates of attendance, meron po, I think we have 2 or 3 po that have asked patungkol po sa kanilang certificates of attendance. So please keep sending those inquiries po to our up.edu.ph email account. Those who have watched at least 50% of the webinar duration, sila po ang makakatanggap ng certificates of attendance. For our webinar today, as always, we'll be having our standard panel discussion format. And after our speakers have presented, that will be followed by a Q&A session. We will now proceed with the topic at hand. Dr. Estela will introduce our main speaker for today.
Our speaker is none other than Clinical Associate Professor Dr. Sybil Bravo. She's the chief of the Division of OBGYN Infectious Diseases at the Department of OBGYN, UPPGH, and the immediate past president of the Asia Oceania in Genital Infections and in Neoplasia in the Philippines. She is also the immediate past president of the Philippine Infectious Disease Society of OBGYN. Let us welcome Dr. Sibyl Lizan Bravo. Sibyl, thank you.
So thank you very much, Dr. Estela Jose, Dr. Sarmiento, and of course, all the dignitaries in our room. It is again my pleasure to deliver this lecture about rational use of our antibiotics. Okay, so we have heard from the people who were interviewed that they somehow have knowledge of antibiotics, but what we are now telling them is how to use it judiciously. So this will be the outline of our lecture. So we have heard that people are dying. Well, because sometimes drugs are not available, or they are available but they might be of poor quality, or in some settings you might have poor access to these drugs. There might be shortage, no drug shortage, but sometimes drugs are really used irrationally. So what is antimicrobial stewardship or AMS? It is actually a set of coordinated strategies to improve the use of these valuable antibiotics with the primary goal of enhancing patient health outcomes, reducing resistance, and of course, reducing unnecessary healthcare costs. It consists of approaches to educate and support us doctors and other healthcare professionals to follow evidence-based guidelines in prescribing and giving antibiotics. So what is now antimicrobial resistance or AMR? Well, in layman's terms, it means there is a change in the behavior or habit of these organisms such that antibiotics do not work anymore. So yun po yung madaling definition, right? So they will be able to withstand treatment. That's it. And that's why sometimes you have no choice but to use high generation and more expensive antibiotic agents. Now, what is the evidence for the ever-increasing problems with resistance? Well, even in high advanced countries, in far advanced countries, they're using antibiotics left and right. So, for example, in US, they have been using antibiotics left and right in veterinary medicine. And also in Europe, they also acknowledge that there have been many instances of infections that have devolved or rather developed resistance to antibiotics. And this would now cause increase in mortality rates. Now, what is the problem with increasing antimicrobial resistance? Well, due to the increase in use of antibiotics by humans, so that's us, between 2000 and 2010, so that's the past decade, 20% of global mortality has been attributed to infectious diseases, and much of this are actually with problems of increasing resistance. Now, what are nosocomial infections? These are actually hospital infections that have been identified as prominent causes of morbidity and mortality. So that would result to increased hospitalization and associated healthcare expenditure. So more than 15% of nosocomial infections are due to multi-drug resistant organisms. So that's now the main problem. Now, where are the local evidence? Well, we have this article that was published early this year about irrational use of antibiotics, in which they highlight that it's actually a significant driver of resistance in our country, with prevalence rate of as high as 31 to 66%. And they also mentioned that self-medication is still highly prevalent in our country. Now, these are the reasons for increasing irrational antibiotic use. Again, no physicians, no, some of us would tend to prescribe antibiotics for viral infections. So pag nilagnat, may ibut-sipon, some doctors would tend to prescribe antibiotics right away. Self-medication, although in the past 2 decades, our own Department of Health and local government have been really very strict, and of course, under the guidance of the FDA, they have been very strict and the prescription rules. So they would require prescription for all antimicrobial agents. Kanina nabanggit yan sa interview, ano? But in rural areas, sometimes people or patients can still get antibiotics from the drugstore without prescription. Ayan. And again, as was mentioned early on, the same with far advanced countries, antibiotics are, well, quite frequently used in veterinary medicine or in agricultural practices. The authors have identified certain solutions to the problem, and we will deal with this later. So, under the leadership of DOH, so the DOH should be our main leader in promoting antimicrobial stewardship. So, hospitals should adopt different AMS programs to ensure evidence-based use of antibiotics. There should be continued surveillance. So, it's actually our antimicrobial resistance surveillance program of the RITM that would cover for all of this. So they look into the different practices of government as well as big private hospitals, and they get the different antibiograms and collect all data. And they would now tell us which antibiotics should not be used or those which can still be utilized. Now, we should also hold public education campaigns, so such as these ones that we are holding through CME lectures, conventions, so we should educate everyone about rational antibiotic use. And now this is the fourth guideline. There should be mandatory prescription for all antibiotics, so that would include antibacterial, antifungal, antiprotozoal, as well as antiviral agents. And there should be stricter monitoring of use in veterinary medicine. Now, we are not just the ones responsible, no, for the success of these different antimicrobial stewardship programs. So together with us, we should ask the help of our pharmacists, the microbiologists, the lab technicians, of course, our dear nurses, and all members of the healthcare professionals to enforce antimicrobial stewardship programs. It's just that as physicians, we are the team leaders. So these antimicrobial stewardship goals, as I had mentioned earlier, should be able to ensure, no, and reduce healthcare-associated costs by decreasing hospital stay and decreasing use of high-generation antibiotics. We should also be able to minimize resistance problems and reduce, of course, not we want to decrease the associated adverse events. And we want to prevent antimicrobial overuse, misuse, and of course, abuse in both inpatient and in the outpatient setting. These are the different core elements, and we will discuss this one by one. So there should be leadership commitment, accountability, drug expertise, action, tracking, reporting, and of course, education. So, for the first strategy, it is leadership commitment. So, leadership meaning there should be the team leader, right? But as I've mentioned, the team will not work without the members. So, kailangan po tulungan tayo. So, there should be formal statements to improve and monitor use of antibiotics. There should also be training and education and ensuring that the staff from relevant departments are given enough time to contribute to these activities. And again, from the government and other NGOs or private institutions, there should be dedicated financial and information technology resources. The second strategy is actually accountability and drug expertise. So as I've mentioned, the leaders are usually us, the doctors. So we should be under the guidance of the physicians who are with formal training in ID or infectious diseases, and we should all learn about stewardship programs. So hand in hand, we should be able to work with our clinical pharmacist as the co-leader. And in many hospitals, especially in big institutions, it has shown improved outcomes. Now for the action, ito yung marami po, no? Kasi nga action, so kailangan meron tayong ginagawa. So we should be able to implement policies that would support optimal antibiotic use, of course, for the right patient, the right diagnosis, the right duration, and the right dosing. So we should be able to prioritize intervention based on the needs and of the care setting. So we should specify, as I've mentioned, the 4Ds, the correct dose, duration, and of course, the indication on documentation or the diagnosis. We should all be guided by, as I've mentioned earlier, clinical practice guidelines, the local susceptibility patterns or antibiograms, and of course, national guidelines. So, broad intervention would include antibiotic timeout. So, kailangan lahat po ng members of the team are aware that this doctor has prescribed this antibiotic, especially in the inpatient setting. There should be prior authorization, so later I'll show more examples, prospective audit, and feedback. So, prior authorization means we need to get the approval of a higher level disease specialist as the infectious disease specialist, and before we give out the continued doses of a restricted antimicrobial agent. Pharmacy-driven interventions would include, ayan po, this is the time that we might have the need of the clinical pharmacist in dose adjustment, optimization of the dose, of course, considering the organ dysfunction, and we should be able to perform therapeutic drug monitoring. We should be also alerted with regard to unnecessary overlapping spectrum of antimicrobial coverage. Later, I'll show some examples. And our pharmacists can also help detect and prevent drug-drug interactions. So, for example, for UTI, we should be able to use narrow-spectrum antibiotics to avoid collateral damage. And for community-acquired pneumonia, skin and soft tissue infections, we should all be preferably culture-guided. Now, for the first clinical case, we have here a 32-year-old gravid to para 1 who consults you at 27 weeks. And she complains that her urine is sometimes colored and she has pain on urination. So what do we do first? Do culture sensitivity, offer treatment right away, do urinalysis, or we confine her? Before we answer that, let us now have a quick look on the CPG on UTI. So what is asymptomatic bacteria in pregnancy? It says here that it is bacteria that is from 2 consecutive urine cultures, wherein the bacterial count should be more than 100,000 colony-forming units of a definite uropathogen. So whereas what is acute cystitis? So this time patients are symptomatic, right? So they have frequency, urgency, dysuria, bacteria without fever, and they might have cause of vertebral angle tenderness or CVA tenderness. And of course, the most severe form of UTI is acute pyelonephritis, wherein there's bystander infection. Patients would have the triad of fever, CVA tenderness, nausea, vomiting, and of course, chills and even flank pains. Now, for the management from different culture or antibiograms, these are the more commonly used agents in treating asymptomatic bacteria. So, basahin nyo na lang po, but most of these are first and second generation cephalosporins. That would include cephalexin, cefuroxime, amoxicillin clavulanic acid, and that would also include fosамycin, natrifurantoin, or even cotrimoxazole. Well, cotrimoxazole is safe to use during the second trimester of pregnancy. For acute cystitis, we have the same antibiotics except that they have added certain third-generation antimicrobial agents. And for pyelonephritis during pregnancy, well, if pregnant patients would have this condition, we should admit them because first we have 2 patients, not just the mom, but we still have to, of course, take care of the unborn baby. And of course, we should be culture directed. So for our patient, she's pregnant, highly symptomatic with pain on urination and slight hematuria. What is our next step? So remember, she's symptomatic. So she has acute cystitis. We could offer treatment right away. For the second case, so 27-year-old BPO agent goes to your clinic with 2 days of cough with phlegm and undocumented fever. She tells you that her coworkers are also coughing. Ayan. So what is your diagnosis? A, community-acquired pneumonia, viral, or community-acquired pneumonia, bacterial, or C, don't give out your diagnosis, do sputum studies first, or D, we confine her for us to be able to diagnose her condition. So before we answer this case, let us have a quick review on the CPG on community-acquired pneumonia among adults. So, can COP be diagnosed accurately by history and PE? The answer is yes. Because from this definition, it says here that it is a lower respiratory tract infection acquired in the community within 24 hours to less than 14 days or 2 weeks. And it presents with acute cough, and patients can have tachycardia or slight fever with at least one abnormal chest finding such as bronchi crackles or wheezing. So for our answer, what is your answer? Letter B. Ayan. Kasi nasa community setting, no, and she's not that toxic. So it's most likely bacterial with a yellowish phlegm. What is our next step? Give empiric treatment, confined, do sputum studies, and chest x-ray as outpatient, or treat as high-risk patient. So before we answer that, let us have a quick review on the clinical diagnosis. So it says here that, well, chest x-ray is still of value in diagnosing community-acquired pneumonia. Essentially, of course, to diagnose pneumonia, to assess severity, or more importantly, to differentiate it from other diagnosis, especially among the elderly. Baka po kasi meron siyang ibang conditions, so we need to rule that out. So, are sputum, ayan po, culture studies needed before we diagnose CAP? The answer here is no. Ayan, so gram stain and culture is not recommended for low-risk pneumonia. Pero pag high risk, of course, it is highly recommended. So, in answer to our query, ano ba siya? Community-acquired pneumonia, low risk, and as such, we can start her on empiric treatment. So what do we now prescribe? IV antibiotics, oral quinolones, or none? Give vaccine only, or give an empiric beta-lactam or a macrolide? So again, for the quick review on the management, empiric therapy of community-acquired pneumonia, low risk, it says here that we can still give amoxicillin ayan, in this following dose, or even clarithromycin, or azithromycin. So these are all strong recommendations with low quality of evidence. So for our answer to this question, to this case, we can actually give her an empiric beta-lactam or a macrolide. Kung low risk po without comorbidities, we can still give her amoxicillin. But if low risk with comorbidities, such as asthma or other conditions, but with stable vital signs, we can give cefuroxime. Now, the next step is tracking and reporting of use and outcomes. So, as we have mentioned, no, the stewardship programs have to be in place in different hospitals, institutions, and of course, later, no, they should be out and available and practice at LGU clinics. So, this example that I have given is from the Centers for Disease Control in US, wherein they use the networking as their system to track and report use and outcomes in the different states. So their program automatically collects data and reports on a monthly basis the duration of therapy data, and later analyzed in aggregate by specific agents and patient care locations. So what our ITM now is doing, they're continuing with the ASRP, wherein they collect antibiotic use in different hospitals, regions, and they collect the different antibiograms. And they release, no, ideally every quarterly, this set of data for different hospitals, institutions to be guided on which antibiotics are with high resistance rates or which antibiotics could still be in use. So we should be able to track outcomes that measure impact of interventions, and these have been shown to help optimize usage of antibiotics. So the WHO 2 years ago in 2023, no, they have published this article or guidance regarding how to accelerate national and global response to the problem of increasing antimicrobial resistance. So these are different strategic processes that would help address the increasing resistance patterns. So they said that, of course, there should be universal access to water, sanitation and hygiene, and waste management. They also mentioned that there should be universal access not to healthcare, to essential healthcare services, and there should be a strategic information foundation, and there should be effective governance foundation in different key cities. So in the local setting, we also have these different guidance or guidelines. So in 2018, our DOH, together with infectious disease specialists, particularly from the PISMIP group, have released a national antibiotic guidelines. So lahat po ito, if you search on this, these are actually downloadable from the internet. We would be able to see po the different regimens that are recommended for the different infectious processes. And they also published in 2016, so even earlier than the NAG, the Antimicrobial Stewardship Program in different hospitals. So this set of interventions would address the correct or rational antibiotic use and implementation of these different stewardship programs. So again, as I've mentioned, at the national level, we have been teaching everyone in the structure and direction to healthcare facilities to adopt this proactive multidisciplinary approach. So all hospitals, it says here, shall adopt to their local context the national antibiotic guidelines to optimize antibiotic use and help improve the quality of patient care and patient safety. So under this, we have the different strategies. So we have the de-escalation therapy. What is de-escalation? So it says here that we should be able to target the causative organism. So we frequently do culture studies, right? For us to streamline our choice of antibiotics. So essentially, when patients are clinically improving with your empiric therapy, we could be now culture directed with our step down therapy. This would now decrease exposure or of our patients to high generation antibiotics, thereby decreasing healthcare costs and, of course, adverse events. And in some far advanced institutions, this is where we also see the advantage of having the clinical pharmacies. So sila po yung pwede mag-guide sa atin to alert us that we could now shift from high generation to culture-directed therapy. This also would include the principle of de-escalation, avoiding irrational combination of antibiotics. So when you're considering polymicrobial infection, piperazine tazobactam is well enough. We don't have to add metronidazole if we want to address anaerobic organism, especially Bacteroides fragilis, because most of the time, piperazine tazobactam has adequate coverage against anaerobic bacteria, except of course in more severe cases. Ayan. We also choose those with narrow specific coverage, such as we use carbapenems when we want to address pseudomonal infection. And of course, when we get negative cultures, please stop antibiotic use. We also have to utilize antibiotics considering their bioavailability. So depending on the site of the organ involvement. So for example, during some pneumonia process, it's the lungs that are the ones that are affected. The following antibiotics are best to use because they have high therapeutic levels in treating pneumonia. And we also have to consider the penetration to the site of action, such that in cases of pelvic infection, we could use cefoxitin plus doxycycline. De-escalation therapy also means choosing those antibiotics with narrower spectrum of activity, again to avoid collateral damage. Collateral damage is a principle in microbiology wherein when you're targeting a certain organism but you're giving a broad spectrum antibiotic, all the other host organisms are gonna react to that antibiotic. They could become pathogenic, and the original pathogenic bacteria could now develop resistance against that broad spectrum antibiotic. So in majority of cases, we should be able to shift to narrow spectrum antibiotics. We also should consider dose optimization in considering the age, the real function of the patient, again, the causative organism, the PK/PD characteristics of the drug, and of course, the site of action. So this is an example. So I'm sure most of you have learned about the Cockcroft gold formula in competing for the creatinine clearance. This would go well among our patients who are elderly and those with comorbidities. Even among children, no, as long as they have comorbidity, and among pregnant women also, we should be able to compete for the creatinine clearance and adjust the dose of our antibiotics. So ito po yung formula, no? Tinan nyo na lang po. So for an example, a 70-year-old female who weighs 50 kilograms with serum creatinine value of 140 millimoles per liter, you are to give now your antibiotic. Would you need those adjustment? So from eyeballing, parang is slightly elevated yung kanyang serum creatinine. So when you consider this formula, so for females, we have to multiply the result, no, by 0.85 to account for the lesser protein mass of women, of females. So her creatinine clearance is just 26 milliliters per ml, and as such, she has renal insufficiency. And so, when you're considering use of IV cefuroxime with the regular dose of 1.5 grams every 8 hours, when you have patients who have renal insufficiency, such as our index patient, you have to consider those adjustments. So ngayon, mas matipid, no? You only give 1.5 grams every 24 hours. So we should always be able to compete for this to avoid, of course, no nephrotoxicity of these antibiotics. So another consideration is the duration of therapy. So it says here that even for complicated intra-abdominal infections, 4 to 7 days of antibiotic therapy is well enough. For uncomplicated skin and soft tissue infections, 5 to 10 days is well enough. And these are the other examples of infections wherein we should be able to limit the duration of use of these antibiotics. Next principle is use of antimicrobial order forms. So frequently, this involves the stop order. Ayan. So minsan nag-aaway-away po yung mga healthcare professionals. Why are you ordering to stop the antibiotic use of my patients? It's because this is one of the successful interventions, no, in the hospital setting in which we could limit antibiotic use. As I mentioned earlier, for some highly restricted antibiotics, we need to obtain the approval of the ID specialist in our hospital. So we have 10 or 12 or so highly restricted antibiotics. Of course, when you're giving the initial dose, the loading dose, there's no need for approval. But for the continuing doses, for the succeeding doses, we need to fill out the certain forms and submit this to the infectious disease control unit of your hospital for approval. So these forms usually contain, of course, the patient data, the diagnosis, and the rationale for prescribing such high duration antibiotics. So essentially, this would actually limit use of high-gen antibiotics, of course, to prevent increasing resistance. So one of the last strategies is, of course, education. So hand in hand again, we should be able to educate everyone on the right prescribing habits. We should be able to educate everyone about the ever-increasing resistance problems. And of course, we should be able to educate everyone on the proper use of antibiotics per disease entity. It is most effective when paired with corresponding interventions and outcome. So what are the examples? Actually, we have been doing this, no? Um, since we were educated in medicine. So we have in-service trainings, we have face-to-face workshops, and during the pandemic po, hindi naman tumigil ang ating teaching strategies. We could also do this hybrid or through online CME courses. Ayan. So in clinical environments, this would include doing rounds with the consultants, with the fellows, with the doctors and nurses and pharmacists, so that everyone will learn on the case. This would also include attending conferences, orientations, and the pharmacy and therapeutic committee of your hospitals would be most helpful if they release drug bulletins in their pharmacy website. So we should also be able how to step down, no, from parenteral to oral therapy. So there are certain disease entities with clear-cut guidelines. So kindly follow these guidelines. But of course, everything will be on a case-to-case basis. Kung sa tingin nyo po, you need to extend a bit use of IV antibiotics, then you may do so. But please always be justified. So in summary, these are the core elements of success that we have discussed. We should be able to review and apply clinical practice guidelines. We should learn how to de-escalate therapy. We should be able to learn how to use antimicrobial order forms. Ito po yung pinapaalam yung use of hygiene antibiotics to the ID specialists in our hospitals. We should be able to apply the principles of dose optimization, considering the age, creatinine clearance, the weight of the patient, and of course, the site of infection. And we should be able to know how to shift from parenteral to oral therapy and when to stop antibiotic use. And of course, again, we should be able to provide education for everyone. As winning the warfare against increasing antimicrobial resistance should begin within us. So please do not overprescribe. And these are the different strategies that we have discussed. Avoid overprescribing, minimize use of broad-spectrum antibiotics, and of course, avoid use of combination therapy when it's irrational. And we should be able to follow guidelines except on a few cases wherein you deviate, no, a little from the guideline. And of course, avoid use of wrong dose and wrong dose interval. Thank you very much for listening. I hope you have imparted much knowledge on this topic.
All right, thank you so much, Dr. Sibyl Bravo. Ako po marami po akong natutunan. And then hopefully
Excellent
sana po yung
lecture
iba
by
rin po ay
Dr.
marami
Sibyl
din po
Bravo.
silang natutunan. Ma'am Stella, any comments po muna before we proceed?
Excellent lecture by Dr. Sibyl Bravo. So sabi ko nga sa fellows namin, nako, dapat nakinig kayo sa lecture ni Sibyl. So sabi ko, hiramin ko yung recording para mabigay ko din sa kanila. So for our audience, no, you can easily do that, no. So marami tayong,
Correct.
lalo na ang daming doctors dito sa group na to eh. Halos lahat sila doctors. So malaking tulong, Sibyl.
Very, very fortunate. Thank you, Dr. Bravo. We'll call you in again during the Q&A. We'll just take this opportunity to greet those from the DOH Treatment and Rehabilitation Center in Argao in Cebu, Mariano Marcos Memorial Hospital and Medical Center in Batac, Ilocos Norte, West Visayas State University Medical Center in Iloilo City, Iloilo, St. Marina Kidney Center Incorporated, Baguio, Benguet, and St. Mary's Educational Institute in Lemery, Batangas. Also internationally, we are being viewed by the Sutra team and Sarantis team as well as from Lee & Co law firm. Meron po Ryan Hall Shanex Incorporated, Bridgewater, Canada, Chonin Hospital in Taipei City in Taiwan, Al-Hada Armed Forces Hospital in Al-Hada, Saudi Arabia. I'll just read through here from the province of Bataan, Hospital ng Binyan. From Province of Rizal, maraming salamat po. Especially mga nagsabi po na nakatanggap na daw po sila ng ating 5th anniversary tokens. We will be checking po kung sabay-sabay po ang kanilang schedule po, no? At sino po at anong areas yung mga nauna po kung sakali po. Also greeting those, we have a group from Algeria. Thank you so much. From the Philippine General Hospital, from Antipolo, thank you. From Iloilo City, from Quezon City, from Quezon Province, maraming salamat po. And from Cebu, thank you so much. Air Force City Hospital Clark in Pampanga. Next po will be our reactor. Our reactor, we've already had her before. Very, very fortunate again. She's the head of the section of OBGYN infectious diseases at St. Luke's Medical Center in Quezon City. Also serves as clinical associate professor, the division of OBGYN infectious diseases at UPPGH Department of OBGYN, and also a member of the task force on reproductive tract infections of the Philippine Obstetrical and Gynecological Society. Please welcome again Dr. Nikita Valerie Chua. Dr. Nikki.
Hello, good afternoon, everyone. Thank you again for inviting me here. Dr. Sibyl has discussed tremendously about the burden of antimicrobial resistance and everything that we have to do in order to be good stewards of our antimicrobials. I don't think I can add any more. Actually, si Ma'am Sibyl, ano na po namin yan. Parang authority na yan in terms of therapeutics. But I think what we want to emphasize would be our role as physicians, how important we are in guiding the antimicrobials that are available to us. No, there's rising antimicrobial resistance, but the variety of antibiotics, newer antibiotics, are not coming out as enough for us to combat anti these resistant organisms. So Doctora mentioned earlier in a study they noted 31 to 66% of the population practicing irrational use of antibiotics. So we cannot emphasize enough how important it is that we educate our patients on proper use of antibiotics. Okay, that that antibiotics somehow do not always lead to better outcomes. So prolonged unnecessary use increases the risk of resistance, and especially nowadays we were hearing much about people being more on the holistic practices. No, they're very much aware of our microbiomes, the gut, the vaginal microbiome. So we have to educate them that irrational use of these antibiotics may lead to more harm. So it can even predispose patients to opportunistic infections. And then also emphasis on the importance of being guided by diagnostics like cultures, no? So for us to be able to streamline our antibiotics. The clinical practice guidelines are there to guide, no? As the name implies, to guide us on the proper management when we actually give antibiotics. We do not want to be swayed by the patients because, of course, if we see on the AMS stewardship programs, one issue is a fear of litigation. Sometimes there's overprescription of antimicrobials because some physicians parang they feel like their management is inadequate, or sometimes the patients think na for every illness, antibiotic is the answer. So we have to educate our patients, no, when is it needed ba talaga? If we tell them the facts about their illness, then of course, as physicians naman, we have some form of parang they have respect towards you kasi you're the one nga, as we've heard earlier in the interview of our some respondents, no, they believe that the doctors know better, so we have to be able to relay the information then appropriately to the patients, so that even if kung tingin naman natin antibiotics are not needed, kaya natin i-relay sa kanila without them being parang suspicious na we don't know what we're doing. Parang hindi naman natin sila nagagamot. And then, another issue would be on the institutional policies. No, Dr. mentioned the different strategies, institutional strategies such as yung pre-approval forms, no, stop orders, automatic stop orders. There's also some form of may issue then between physicians because sometimes the physicians would think na we are policing their management. So we as the team leader, the team members should be aware of our goals. We have to share the same goals so that you will think of the infection control um, staff as allies, no, in safeguarding our antibiotics against antimicrobial resistance. So they're allies and not antibiotic police. And then maybe nowadays you're hearing about a lot of other treatment strategies like phytotherapy so that we avoid for certain symptoms or certain conditions we don't really need to give antibiotics. Those are other things that we may consider in managing our patients. So I think yes, I think that's it for me. I cannot add anything more. Dr. Sibyl has already discussed it extensively. Thank you very much.
Thank you very much, Dr. Nikki Chua, for your response, no? And I hope our audience you value her recommendations, no? Now we are in the open forum portion. I just have a question for Dr. Bravo. So in my other hospital, I noticed that the consultants would prescribe antibiotics, for example, for a cesarean section, and they give it for like one whole week. Huh? So, for example, a cesarean section was done. Then it is so hard to ang hirap baguhin kasi yun na yung nakalakihan nila eh. Nasanay sila na kailangan lahat laging may antibiotic. So, what do you think should we do about this, Dr. Bravo?
Actually, ma'am, that's one of the cases in my lecture. Kaya lang, ma'am, I just limited our lecture to clinical scenario. That's actually one of the examples, best examples of irrational drug use. So, ma'am, anong strategy? Yun nga po yung limit use of antibiotics. So, education, that's through education pa rin po. That's why we're holding continuous conferences, conventions, CME, including these topics. So we follow guidelines. So for low-risk patients and for clean cesarean deliveries, we only need single dose of prophylactic antibiotics. We do not need to follow up with IV antibiotics, and more so, we do not need to discharge them with oral home medication with antibiotics. So yun po yung dapat talaga nating matigil. We have been successful po in doing rollouts po yan no, sa ating division and with the help of some institutions po in providing lectures po to different institutions with regard to use of these antibiotics, especially in obstetrics and gynecology.
Thank you very much for your answer. And there was a question in the chat box earlier on about yung leptospirosis that when we give doxycycline, kasi nga yung pagka may floods. Nikki, what can you say about that?
Yes. Actually, ma'am, of course, eventually continued use of certain antimicrobials as prophylactic agents may lead to eventual resistance, but um, we have to be reminded that the prophylactic use is also intended for certain individuals only. So we do not want to give it as like a mass prophylaxis, no? Na umulan lang, bumaha lang, lahat iinom na. We have specific um, criteria for one individual to get prophylactic antibiotics. So still it is practicing in a way judicious use of antibiotics.
Thank you. Thank you for your answer. Si Raymond, baka may question ka, Raymond.
Stella, nothing from me, Dr. Stella. Papa. Thank you. So we'll take the time out po no to thank our speakers, Dr. Sibyl Bravo and Dr. Nikki Chua, both from POGS po no and also from the Philippine General Hospital. At this point, we'll be flashing on the screens our evaluation poll po no. So okay, there we go. It's 5 questions, 4-point Likert scale. So we're asking everyone to participate po in this panel evaluation. So we have, I think, 166 people in the Zoom, also in Facebook and in YouTube. Dagdag po iyon. Number one, the panelists demonstrated thorough knowledge of the topic. Number two, the panelists were well prepared and organized. Number three, the panelists spoke clearly and audibly. Number four, panelists use appropriate language with technical medical jargons adequately explained. And finally, the panelists contributed to new perspectives and knowledge on managing various key health issues. So we'll not be closing this until the end of our webinar. Thank you again for very rich exchange of ideas and insights po for today. Marami po kaming natutunan po talaga. For next week, we will have a very exciting topic for you. Ano po ba yon, Ma'am Stella, your next week?
For next week, we have Dr. Bernadette Madrid, who is the head of the Child Protection Unit at PGH, and also Professor Legarda.
Ayun, okay. Thank you so much, Ma'am Stella. So in the meantime po, you can still watch us on the playback at the TVUP YouTube channel, also at the TVUP Signal TV channel 101. Before we conclude our program, all health updates webinars are archived for viewing at the TVUP YouTube channel. Just go to www.youtube.com/TVUPPH, or you can open your app, go to TVUP, and you'll be able to see, if you go to the live tab, all 250 episodes. After today, 251 na po siya. Now, if you go to the Shorts tab, dun din po on the same YouTube channel. Obviously, we understand everyone very busy, so we have selected presentations that we feature in snippets. Dun po siya matatagpuan sa Health Updates Shorts po natin. So this formally closes our webinar for the week. We look forward again to your company. Magkita-kita po tayo again next Friday from 12 noon to 1 p.m. It's a date.
Together, we can stop preventable deaths.
So keep safe, keep healthy. See you online.